Hello, Dr. Prior. Welcome to the Menopause Shift Summit.
Hello, I'm happy to be here.
Thank you very much for coming to talk to us about something we don't hear a lot about in this space. And this isn't a surprise to you. You've been studying progesterone up there in British Columbia for a long time. Can you tell me how you have come to make progesterone such a focus of your work? How did that happen originally?
Yeah, it's an interesting story, actually. It was the 70s and the aerobic fitness fad was sweeping the world. And because of that, many more women were doing things like running and wanting to train for marathons and things. And the message from the medical community and the word on the street was it was going to destroy everything. Your period was going to go away, your womb was going to fall out, et cetera, et cetera. Exercise was bad for women. And, I had the strong sense that was, malarkey. So, we started trying to understand whether, what was happening with the menstrual cycle in women who were runners. And we started just with a 3-cycle study. And there were basically the cycle length stayed the same. But what we noticed was that as they were ramping up their exercise beyond what they were used to, then the luteal phase, or the second part of the cycle when progesterone is high, was shortening. Okay, so then I tried to get a grant to look at changes in menstrual cycles over a year in women with different exercise patterns, but all of whom were normally ovulatory, normally cycling at the beginning. And I couldn't get funded for that. So then we figured out a way, this was before we had DEXA and bone scans, to assess bone density by the CT scanner. And when we said, oh, well, exercise is going to cause, they lose their period, then they're going to lose bone. And therefore, there's probably a risk for osteoporosis in these long distance runners. And we got the grant. So we started with healthy, normal weight, non-smoking, normally ovulating, cycling women, and followed them across a whole year. And what we observed was there were no more problems with the short luteal phase or not ovulating in the women who were runners than in the women who were doing ordinary exercise. In other words, it was something other than exercise that was causing these changes in the amount of progesterone. And then the second thing we learned was that those women who had the most disturbance of ovulation or more short luteal phases were losing bone, but the ones with enough progesterone weren't. So that was the first indication that you needed progesterone for bone as well as for fertility. And then since then, we've carried on to examine a lot of other systems where progesterone is absolutely essential. And the idea, people would say, well, you don't like estrogen, that's why you do this. And I said, that's not true. Estrogen is absolutely important, but so is progesterone. And you need to think of the two as being in balance. And so I actually, at the same time that I published a review about progesterone and bone back in 1990, in the same issue, it happened that there was a study of the effects of estrogen and progesterone in all kinds of different tissues, in all kinds of different animals. And so these Australian, Christine Clark is the name of the first author, and these Australian investigators had discovered a common theme, which is estrogen's a growth stimulating hormone. It causes cells to change and grow and make more cells. We know what the word proliferate, because that's what Omicron or the COVID-19 virus does. In other words, it just keeps, making more cells, more virus. Okay, so that's what estrogen does. And it continues to do that no matter what. It doesn't stop. So the body needs something that controls that potential overgrowth. And also what progesterone does that's unique is make each cell more specific. In other words, different cells have different functions, and it matures the cell to its own function. So as well as slowing the overgrowth that estrogen causes. So we need that balance that the normal, healthy ovulatory cycle provides.
And maybe just a primer about for what progesterone is doing for us in our fertility, and then what's happening when we enter perimenopause.
Okay, so the common message that we get is that we only need progesterone to get pregnant. That, that's the only time when we have to think about it, because it's a pregnancy hormone. And in fact, the endocrine, layperson's information about hormone, the endocrine societies, the sort of Bible thing, is estrogen works here in the heart, it works in the bones, it works in the brain, it does all these good things. And progesterone is the body's fertility hormone. In other words, the assumption is that progesterone only works in the uterus, which is not true. It works
Where is it working?
Everywhere that estrogen is, progesterone is.
Okay.
Yeah. And so the other part of that wrong message is that if you have a regular, predictable, normal length menstrual cycle, you don't need to worry, dear, because you're ovulating, you're making an egg. And that is just wrong. And we learned that in that study that I was telling you about, that first big study. Cycle lengths were 99% normal length, but ovulation was disturbed about 2/3 of the time for 2/3 of those women, at least once in the year.
And this is something we don't really know generally, is that just because you're having regular periods, you've been told you were having regular cycles and everything was okay. But a lot of the time you're having a regular cycle, but
the cycle has too much estrogen and not enough progesterone.
Okay. So before we hit perimenopause, we're sort of fighting a situation where we don't have enough progesterone some of the time, some of us.
Yeah, that's right.
Okay.
Yeah.
Does this create more problems in perimenopause if you had that situation before?
Yes, I think so.
Okay.
And we don't really understand yet, because no one's tracked it longitudinally within one woman, or within a bunch of women over time. But it looks like those women who have more troubles with ovulation early are the ones who end up getting heavy flow, for example, which 1/3 of women in perimenopause get. However, that doesn't protect you, being normally ovulatory before doesn't protect you from having heavy flow in perimenopause. So, but for sure, in perimenopause, estrogen is rising and being just highly irregular, but progesterone is steadily going down, even if you continue to ovulate.
Okay. And we just are, what's happening? It's steadily going down. Do we eventually have no progesterone? Or
well, it gets to be as low as it is in a kid or a man.
Okay.
Because there's some that's made, by the system that everyone has. It's the high levels that we need to counterbalance the estrogen levels of the menstrual cycle.
And when you're going through perimenopause into menopause, can you just sort of describe, because again, the focus is so much on estrogen. Can you just sort of describe the progesterone is going down, but what is the body designed to do if all things are functioning well, to carry you through menopause with no progesterone. Does that make sense?
Okay. Well, it's okay. You get to balance again in menopause because then estrogen is also low. But the biggest imbalance in estrogen and progesterone occurs, and it seems to be natural, normal, expected in perimenopause. Estrogen is too high.
Okay.
The body makes estrogen very easily, and the body's trying to get rid of all your follicles that have an egg, so you're not going to have a period when you're 80 in a nursing home.
Okay.
So,
so when you go to the doctor, when you are in perimenopause and you're complaining about symptoms, and we'll get to your research soon, but why is the focus on estrogen? If estrogen giving you estrogen, if in your opinion, if estrogen is going up and down or is high and not on progesterone?
okay. Because we misunderstand that starting to have night sweats, we think that starting to have night sweats means your estrogen is low, because we think of hot flushes and night sweats as being part of menopause, when the story is we are estrogen deficient. Okay, so that's a mistake, a mistaken understanding. And the other mistaken understanding is that basically often perimenopausal women are just not interested in sex, so they're not having much. And when you don't have much, you get dry. When you feel dry when you do have it. And that's another thing that we think of as estrogen deficiency. But it's equally occurs in a woman of any age who's not been sexually active for a while.
Okay.
So those two reasons, the start of hot flushes or night sweats make us think, which begin in perimenopause, make us think that estrogen is low. So does vaginal dryness.
Okay.
And it has become a reflex. If anyone has hot flushes, they're estrogen deficient.
Okay. You did write a piece which made me become more aware of your work in Scientific American recently about, is estrogen deficiency basically a thing? Because that's all you hear. So you have to that when someone's hearing what you're saying for the first time, it's like kind of making their mind blow, right? So you wrote a piece like that, which goes counter to sort of 90% of what you read. What do you say to that?
Well, I think we forget that estrogen deficiency is a marketing term for selling estrogen. It was, because it began in the 40s, we think it's, just part of our cultural, our language. But it's just like an ad for any other drug. That's a marketing slogan, and it's a very clever one. Just like hormone replacement. Again, a marketing term.
Okay. And no one's saying estrogen isn't helpful or that you might not need it. You're not saying that.
I am saying don't take it until you've been a year without your last period.
Okay. And that runs counter to a lot of what we're hearing now. We're hearing you can take menopause hormone therapy in perimenopause as soon as you start having, and you're saying that's not true.
That's right.
Okay.
The concept is, or the assumption is, that if you have hot flushes, your estrogen is low, therefore you need estrogen and a little bit of progesterone or progestin to keep from getting endometrial cancer. And the guidelines all say menopausal hormone therapy is the right thing to take for symptomatic perimenopause without any evidence. Show me the randomized controlled trials that it's effective and safe in perimenopause. And there aren't any.
So why is everyone saying that there is? Do you think?
because they have wrong ideas about what the hormonal changes of perimenopause are.
Okay.
I mean, that myth is so hard to die. But if you think about it, I mean, my very difficult perimenopause was characterized by heavy flow, sore breasts, night sweats. Well, sore breasts don't go with low estrogen. In fact, I and many other women around the world, in fact, a Kung woman of the Kalahari Desert reported dreaming they were pregnant
Okay.
at that time of their lives. Well, pregnancy is a time when hormones are sky high.
Okay.
So our subconscious knows estrogen's too high or very high. Just because the doctor doesn't know it doesn't mean it's not true.
Okay, so you published, you conducted a clinical trial on progesterone and published it. Can you tell me how that came about and when it was published and where it was published?
Okay, sure. Actually, this is a unique randomized controlled trial because it was entirely funded by donations.
No conflicts there.
To the Center, to the Center for Menstrual Cycle and Ovulation Research. And the makers of progesterone, oral micronized progesterone, donated the drug and placebo with no strings attached. So we did a randomized controlled trial with 132 women completing it. The purpose of the trial was to find out whether it was effective at decreasing hot flushes or flashes and night sweats. And it did significantly more than placebo. And it was published in 2012 in the journal Menopause.
Okay. Now, right away, people will say that's a very small study, Dr. Prior.
Most studies of hot flushes have only 100 women in them.
Okay. Okay.
So it isn't a small study in that context.
Okay. So you found that it was effective for hot flashes and night sweats. And then when you had your own perimenopause, tell me about that. I'm curious about your own experiences.
Okay. Well, I recognized that estrogen levels, well, this was before it was in the literature. I recognized that estrogen levels must be high in contrast to what I'd been taught. And I actually used progestin. We didn't even have oral micronized progesterone at that time to deal with heavy flow, and ended up using it, starting to use it for night sweats and hot flushes. Night sweats were the worst for me. And took it, well, I changed over to oral micronized progesterone when that became available. And in total needed it for 7 years.
Okay. And did you ever take estrogen?
No.
You never did. So you're kind of saying something, again, it runs so contrary to what we're used to hearing, but you're saying progesterone first and maybe never estrogen.
That's right.
Okay. And progesterone.
Think about it for a second. I mean, progesterone doesn't cause migraine headaches. It doesn't cause blood clots. And the evidence is it probably doesn't cause breast cancer. It may prevent it. So estrogen does all those bad things. So why would you take it if you didn't need it?
You're saying it's something that people can try before they go on estrogen. You recommend estrogen after menopause. And also,
Wait. Most of the time, if menopause is at a normal age,
yep,
women don't need estrogen therapy. Progesterone is sufficient.
Okay.
So, I mean, there aren't any long-term benefits. Heart disease, it increases, estrogen increases the risk of breast cancer. There are more negatives, even with transdermal estrogen, than there are with progesterone. Just that's what the record shows.
Okay.
It's not just me.
It's not just you. We do hear all the time, though, that we should be taking menopause hormone therapy, including estrogen, to protect us from cardiovascular disease, to protect us from dementia, to protect us from
It doesn't.
osteoporosis.
Okay, so it does help bones,
Mhm.
but we have other medicines that work in a similar way and that are safer.
Okay.
So there's no recommendation by any major body to take hormone therapy to prevent osteoporosis or
Okay.
to treat it.
Okay. And what else do you suspect progesterone can do for us in perimenopause? And when I say suspect, you have to be careful, because if you haven't done a study, but what do you, what's your areas of inquiry?
We have done a study.
Okay.
We completed the study in 2017. We reported it at the Endocrine Society I presented it to an audience then, not just an abstract on a board. And we've been trying since then to get the results published without success. I mean, so far, I guess what's new is that just recently we have a BMJ Open article out showing that there appears to be gender bias by the editorial desk at the major medical journals, not only against women authors, first and senior author, but also against topics that are not diseases and that are new discoveries related to women's health. There were none in 74 articles that we examined after our own papers were rejected.
Okay.
So there's this bias that is not important. Women's health is not important. It's not interesting. It's not science. So again, this new information has been rejected by all these journals. But we do know from what I presented back in 2018 that there's a significant improvement in women's perception of night sweats if they're on progesterone compared to if they're on placebo. In that perimenopausal study, we had 189 women in that study. And it turns out that the hot flushes are so variable that we needed, 250 women to finish in order to have enough statistical power to show that progesterone worked.
Okay. Now, what about some other things? We hear that progesterone can help with migraines. We hear that progesterone can help with sleep, mood.
The sleep is very clearly documented. Randomized controlled trials of 300 milligrams, 3 little balls of the progesterone at bedtime significantly improves sleep overall, especially the deep sleep, slow wave sleep in both men and menopausal women, and decreases sleep disturbance. So if there's noises outside, or the telephone rings in the middle of the night with a spam call, or whatever, it's less disturbing. And the new data that we have on perimenopause again says that sleep is improved.
Okay.
Yeah.
So I lost my train of thought there. I'll have to edit this out. What about, okay, how should a woman go speak to her doctor about this? Because I know from interviewing, I've probably interviewed dozens of doctors by now, and I always ask them about progesterone, and I often just get sort of a blank stare. Progesterone is something
either a blank stare or you've been on the internet, and you should never pay attention to the internet.
Yeah, progesterone is to oppose estrogen to prevent you getting endometrial cancer. That's basically the only reason you would ever give estrogen or give progesterone with estrogen. That's over and over and over. When I ask the mainstream doctors about it, that's what I get. So any woman who watches this is going to think, okay, go in and talk to them. How would you advise them to just bring this up?
Okay, I would suggest they say to their doctor, well, estrogen and progesterone are both important in the menstrual cycle. And there's new evidence that they need to be balanced for optimum long-term health. In fact, what our 2020 some review shows is you need it for bones, you need it to prevent early heart attacks, you need it to prevent breast cancer and endometrial cancer. So those are big things for older women.
Okay.
So start with saying, well, progesterone's important in the normal menstrual cycle. And the evidence is that wherever in our bodies that estrogen does positive things, progesterone is also doing positive things.
Okay. Can progesterone have any impact at all, do you think, or know, or suspect on any of the genitourinary symptoms of menopause, any of the vaginal dryness or anything like that you mentioned before?
I think so, but we don't have good evidence.
Okay.
I don't know of any good study that's tested that.
Okay.
It takes extremely small amount of estrogen, if estrogen's needed at all.
Okay.
And women need to realize that you can absorb estrogen very well through the vagina. So if you take a large amount, it's like you're taking the estrogen, systemically. So in general, once a week, vaginal estrogen is sufficient.
Okay, this is also something you don't hear very often. You hear it's very, very safe. Yeah. Okay. So one other thing that you told me before is how when we're used to Googling the menstrual cycle, the diagrams that come up are wonky. Can you explain how that is?
Yeah. Okay, so we have to start with something that sounds a bit scary, which is talking about the units that estrogen and progesterone are measured in. But estrogen is in picomoles or picograms, depending which country you're in. But progesterone is in nanograms or nanomoles. Now, a picogram is 1,000 times smaller than a nanogram. And therefore, when we see a diagram that doesn't have any units on the side of it, that making estrogen look like it's lots bigger than the progesterone it's just wrong. It's fraud, really. And yet that's what we all know.
It's not apples to apples, as they always used to say when I covered city council.
I mean, when you draw them to scale, estrogen looks like a little pimple and progesterone looks like a huge plateau.
Okay.
In terms of the actual amount of change in those two hormones from their baseline, which is low during flow, to their peaks, it's a huge difference. Estrogen rises 200%, progesterone rises 1,400%.
Okay. Okay. The other thing, I think we've discussed this before, that estrogen has sort of addictive properties when you take it, and progesterone doesn't. So you may, a lot of women talk about down the road reverberation of their symptoms. Can you talk a little bit about that?
Yes, because dropping estrogen levels trigger a huge release of all kinds of neurotransmitters and cytokines and things, often from the brain. And that's part of the addictive response. It's like an addict who doesn't have his fix, and that's a physiologic thing, which means that about a quarter of women who've been put on, especially if they were put on estrogen alone, let's say they had a hysterectomy in perimenopause and were symptomatic, they're usually given estrogen alone. 10 years later, when they come to doctor, should I keep on taking this hormone, etc., they'll have a hard time stopping it, because as they decrease the dose, the symptoms get worse. And so I should say that there's two things we know now that are related to that dropping estrogen. I mean, well, there's more than two. We know it causes bone loss, rapid bone loss, but we now know that it's what causes the hot flush. That stress hormone released from the brain is what triggers hot flushes. But thirdly, it also triggers anxiety and depression. It changes mood. So the perimenopausal, emotional upheaval is part of that dropping estrogen.
Okay. So where would you like to see, if you had an unlimited budget and you didn't have to take money from any sort of company and you could just research to your heart's content, what would you look at?
Okay, the first thing I would do is to do a randomized controlled trial of the common therapy now for perimenopausal bleeding, which is birth control pills, versus 300 milligrams of progesterone every day for 3 months. Because my clinical experience is that is effective at treating perimenopausal heavy bleeding. And will save all kinds of hysterectomies, DNCs, endometrial biopsies, the hassle of suddenly bleeding through onto your clothing, all that stuff.
Okay.
So I would do that study first. I would do a larger study, a comparative trial of menopausal hormone therapy versus progesterone alone, 300 milligrams at bedtime, for perimenopausal hot flushes and night sweats.
Okay.
I would answer that question. We'd probably need 1,000 women in the study. But if they're common enough, we should be able to do it.
Are there women, I mean, I've heard there are women who don't respond well when they take progesterone. Have you had that experience?
No, very, very, very few.
Okay.
I mean, yeah, if you go to your doctor and your doctor says, well, you could take progesterone, but it may make you feel blue, and there's a risk of blood clots and breast cancer, you're likely to expect something negative.
Okay. Now I have friends who have the Mirena coil, and they seem to be having an easier time of things. And I know it's impossible to say what the other variables would be in their life, but is it, there are women, and someone just asked me this on social media the other day, why wouldn't I just get the Mirena coil put in, have it through till I go through menopause and take it out? Can you sort of speak to that? Because that's not progesterone, that's progestin.
It's progestin, and it's a male hormone type. In other words, that has androgenic characteristics.
Okay.
It is an alternate way to treat heavy flow, but we don't have any evidence that it helps hot flushes. Okay. We just don't.
Okay.
And I don't know if there's any evidence it helps dryness.
Okay. You've been looking at this space for so long. Is there some sort of corporate, we have to be careful, but is there some sort of corporate, is there some sort of financial benefit to the focus on estrogen? Is there more money to be made from the sale?
It's a combination. I think the estrogen lobby early, shortly after it was characterized, chemically characterized, etc. Immediately the gynecologists started using it for therapy. As soon as a chemist would make it, they would try it out on their patients. And so the whole field of modern gynecology has grown up with that as one of their major non-surgical tool. And because they have been considered the experts in women's health, even though they're primarily trained in surgery, that has become what the culture believes as well. How much pharma interest today? There's definitely pharma interest in birth control pills. of course, marketing is marketing, but I think the bigger issue is the cultural concept that we've adopted that is incorrect, or many concepts actually.
Yeah, just the focus on estrogen at the exclusion of other things. And it just takes that many years, like maybe 50 years from now, we'll be talking about all of them. I just asked in this summit, I asked a neuroscientist about progesterone, DHEA, testosterone's impact on the brain. She said, we don't have any idea. We don't
Well,
really.
that's not quite true.
Okay. What do you think?
No, we have evidence, if you want to be broad, and I'm not a neuroscientist, but estrogen is an activating hormone in the brain, and progesterone is a calming one.
Okay.
We definitely know it works through the GABA system. That's probably the way in which it works on sleep. There was one trial in women with PMS who are premenopausal, given progesterone daily, that showed a decrease in anxiety.
Okay.
So it's I think that's a good concept to have. Again, everywhere we find estrogen acting, progesterone also acts.
Everywhere. Okay.
Everywhere.
And also controversial is progesterone cream, because yeah. So can you just speak to that?
Well, it's controversial for two reasons. One is that it doesn't get into the bloodstream, and therefore it's hard. We say progesterone level doesn't go up; it must not be there, which isn't a correct idea, but it's part of how we think. But the big reason is that in the United States, in particular, the progesterone cream is over the counter. In other words, you don't need a medical prescription for it. In other countries in the world, including Canada, you need a prescription. It's illegal to sell progesterone cream at a health food store.
Okay.
Or, at a health fair or whatever.
Okay.
Yeah.
Is there a benefit to, in your opinion, to maybe trying, if you can get a prescription for it, to trying progesterone cream before you try the progesterone? Is there any?
I don't think so, because some of my respected colleagues would disagree. Okay. But in perimenopause in particular, it simply does not provide a high enough level to counterbalance the effects of estrogen, which is what we're trying to do.
Okay. Why are people using it then?
Well, why do we use anything non-medical? Because we're trying desperately to help ourselves.
Okay.
That's understandable.
Okay. And you had a pretty rough perimenopause, didn't you? You had a pretty rough time.
10 years.
What can you say to women who are struggling now?
You will survive.
We always hear about the other side. What's it like on the other side?
Oh, much, much better. Oh, much, 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 much better. It was like huge relief to me. And to be honest, I probably have, my metabolism of estrogen must be slower than other people's. And that's one variable we don't measure. Okay. Is how the body handles it. But for example, it's pretty well documented that fewer East Asian women have hot flushes, Japanese, Korean, Chinese. And that's usually accounted for by soy. But soy, we did a test of soy milk, a good dose of soy protein, and versus placebos, a milk that tasted the same. We had these taste parties before we designed the study. At any rate, and soy milk just doesn't work for hot flushes. Okay, or soy protein, Any rate, but the reason I think is that genetically, East Asian people more rapidly metabolize and excrete estrogen.
Okay.
Yeah, that's well documented.
Okay. You always hear soy still. You always hear it's the diet and it's soy. Well, thank you.
Food is not going to be harmful. when you first start, you'll have a lot of gas, but your body gets, you get the good bacteria that learn how to deal with it, and you're fine.
Well, thank you very much, Dr. Prior. It's certainly a fresh take when you're spending a lot of time in this field, but you know that, don't you?
I do.
Yeah. Thank you for your work.
And tell women to look for accurate information. The Center for Menstrual Cycle and Ovulation Research website, we've tried really hard to put accurate information there in a way that anyone can understand.
Okay. And you also have like a diary on there that people can use to track
Yes.
their symptoms.
Yes, absolutely. Tracking your own symptoms during perimenopause. You can track ovulation also by just an ordinary thermometer and keeping a record, and we show you how to do it.
Okay.
But it's more accurate than the BBT of the menstrual apps, for example.
Okay. Well, thank you so much. I appreciate
Well,
it.
thank you. It's been a pleasure.
Two things. Would you mind just doing a little promo? Like, would you mind if you just said, I just spoke to Anne-Marie for the Menopause Shift Summit, all about progesterone. Check it out. Or do you feel uncomfortable?
Sure.
I don't want to put you. Okay. You can just do it whenever. I can hide if you want, if you're shy.
Pardon?
I can hide if you want. You can just do it now.
No, okay. I just had a great time talking with Anne-Marie McQueen about progesterone in the Menopause Summit. I think you'll find things there that are interesting and you will enjoy.